Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go snag that free PDF. It's a 31-page PDF on the top 200 drugs. It's a great study guide, great refresher for anybody in pharmacy school, nursing school, or if you're just out in practice and would like a refresher on some of the most important medications in practice. So again, go check that out. Simply an email will get you access to that, and that's at reallifepharmacology.com. All right, the drug of the day today is Bisacodyl. Brand name of this medication is Dulcolax. Now, this is an over-the-counter laxative type medication, and there are numerous other brand names. Okay, so I'm not going to go through the entire list looking that up, but you should be aware that any type of medication where you see, laxative, that type of thing, over the counter, it's best to go ahead and look at the back of that box, back of that pill bottle, and actually see what's in there. So the generic name that you're going to see is Bisacodyl. Again, stimulant, laxative, and mechanistically it stimulates peristalsis. Let's define peristalsis quick. So this is the wave-like involuntary muscle contraction that pushes substances through the digestive tract. Okay, so again, we don't control those movements, right? Our body does it on their own. They're what's considered involuntary, and this medication stimulates that peristalsis action. It does this by directly irritating the smooth muscle of the intestine, and this can alter the water and electrolyte secretion as well, bringing fluid essentially into the gut lumen, which, the more fluid and things you get into that gut lumen, the more and more likely that's going to help stimulate that muscle contraction and a bowel movement, which is ultimately what we're trying to treat in managing constipation. So with that indication, generally this medication is only recommended for short-term relief of occasional constipation. With that said, I have seen it used on a chronic, longer-term basis in some situations. Typically, we're going to prefer medication like polyethylene glycol versus a stimulant laxative like Bisacodyl, but there are rare instances where I have seen it used longer term. It also can be used for bowel evacuation prior to certain procedures as well, or as part of a regimen there. So you may see this medication used in that situation too. Dosage forms. So this medication comes in a couple of different dosage forms. It can be given orally, which is what I see most commonly. I do see the suppositories quite a bit in patients in long-term care, where it's actually a standing order potentially. If oral medications aren't working, you may see this suppository be used or be recommended in that situation. There is also an enema formulation as well. Now, let's talk a little bit about the oral formulation. Usual adult dosing I see is in that 5 to 10 milligram range. You may see it pushed up higher in some instances, but I would say 5 to 10 milligrams is what I'm going to see most commonly there for acute relief of constipation issues. All right, an important administration note with this medication as we're dosing this medication, recommended to give enteric coated tablets, or oral tablets, with a glass of water, and do not crush or chew, which can sometimes become an issue in some of the older patient populations that I work in. I'm also going to cover this in drug interactions, but antacids, milk, dairy can sometimes interrupt the way this medication works. I'll talk about that in a little bit more detail coming up here. But avoid taking within 1 hour of antacids, milk, or dairy products. Adverse effect profile. The most common thing you're going to see is some abdominal pain and cramping, which makes sense. We're stimulating the muscles of the gut, the peristalsis, to go to produce a bowel movement. So if we ramp that up too much, it can certainly cause some discomfort and some abdominal pain and cramping for patients. Other things you might see in probably less common situations, nausea, can increase gas and flatulence, can cause some bloating and fullness as well. And then, of course, if we are giving this medication too much or maybe giving it inappropriately, we can cause chronic diarrhea. And I have seen that in a couple of rare cases where the patient didn't understand or didn't know what the medication was being used for. They were prescribed it a long time ago. Maybe they were on opioids, for example, in the past, and they were prescribed this medication, and it just got continued. And the patient didn't realize that medication was actually being used for constipation and is going to cause diarrhea as a potential adverse effect if we're using too much of the medication. Onset of action, touch on that briefly. It's 6 to 12 hours is when you're going to see this, so that's a good education point to remind patients, like, hey, you're not going to see anything happen immediately. It's not going to be within a half hour or an hour. So that's an important patient education point to set those expectations. How that relates to dosing, I have seen some clinicians recommend giving it at night. So then that can, work overnight, get through the GI tract and produce its effects and, potentially have that bowel movement in the morning. I have seen it dosed in the morning as well, and that work out just fine too. So again, some clinicians you may see recommended taking at night, some you may take it in the morning. The one thing I will say about the morning is if patients are more likely to do antacids, if they're more likely to eat dairy, have a glass of milk in the morning, that might be a situation where that's going to lend you to want to give that maybe in the evening, maybe when they're done eating and those type of things for the evening. The rectal suppository, from a pharmacokinetic standpoint, does produce results faster, as you could probably anticipate. If you're inserting a suppository right into the rectal area, that medication's going to be given really very close to the site of action, or right on the site of action. And so you could expect that that's probably going to work quicker, and that often produces those type of effects within 15 to 60 minutes. So within an hour, you may see some effects from the suppository dosage form. Monitoring parameters, those type of things. Again, for short-term use, really all we're paying attention to is that bowel movement. Okay, so that's what we're looking for. But obviously you want to recommend some of those non-drug intervention things as well. If you've got a patient that's having issues with constipation, proper hydration, fiber intake, exercise when possible, of course. So these are all things that can help prevent constipation going forward. All right, let's take a quick break from our sponsor, and then we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material, like BCPS, ambulatory care, geriatrics, BCM, TMS, or the NAPLEX exam, go check out meded101.com/store. We've helped thousands of pharmacists prepare and pass for their board exam, and we can absolutely help you too. So again, go check out meded101.com/store. If you're a pharmacy technician, nurse, med student, anyone else needing pharmacology education, we've got tons of different resources, many books on Amazon talking about food-drug interactions, case studies, nursing pharmacology, pharmacy technician study guides. All those links, all those resources you can find at meded101.com/store. Your support there goes directly to help support this podcast. All right, wrapping up with drug interactions. First and foremost, there aren't many that are crazy significant, in my opinion. There's no lethal or life-threatening drug interactions with the use of Bisacodyl, in my opinion there. So what I think about first, I alluded to the giving it, an hour before, antacids and H2 blockers and those type of medications. So what that interaction could potentially cause is it may cause the delayed release Bisacodyl tablets to release the drug prior to getting to the site of action, more so the large intestine and the rectal area. Okay, so that's why we don't want to do milk, dairy, antacids, and those type of things. It's going to interfere with the effect of that medication and potentially cause issues with regard to gastric irritation if that drug is prematurely released, and then possibly interrupting the efficacy as well. So pay attention to that when patients are taking it. Particularly pay attention when you've got a patient who's a non-responder. So, say they've taken it for a couple of days, they're not really seeing any response, any benefit from it. That's a good question to kind of double check and ask is, are you taking it with milk, dairy, antacids, H2 blockers, as those can kind of interfere with the medication. The other thing I think about is concomitant use with other laxatives or medications that can cause diarrhea, and that can ultimately lead to dehydration and electrolyte imbalances. Again, not crazy common with most patients because we're just going to be using this for acute relief of constipation. It's probably more so in the patients that are taking this, kind of moderate to longer term. We're talking a couple weeks to beyond that. If you've got patients that are susceptible to electrolyte imbalances, medications that add on or contribute to diarrhea, that's maybe a situation where I'd watch that a little bit more closely. But obviously, if you've got a patient having diarrhea, we are, likely not going to be using this medication, right? Because, we're using it to treat constipation. So pay attention to that. Ask patients what's going on, clinically monitoring them. That's going to be the important thing there. And then last but not least, from a polypharmacy prescribing cascade perspective, when you have a patient reporting constipation, always do your work and go through their medication list and make sure there are meds on there that aren't causing constipation. Okay? Virtually every geriatric patient is probably taking a medication. Well, not everyone, but I think you get the drift. Any patient taking probably 5, 10 or more medications, odds are likely they are taking a medication that can contribute or cause some constipation. So pay attention to that. Opioids, anticholinergic medications, calcium channel blockers for hypertension. Sometimes if patients are, underdosed on levothyroxine, and they're having hypothyroid symptoms, there's another classic example that can cause some constipation. Think about these things. When a patient presents with constipation, look at that medication list, look at that past history, look at that medical history, and make sure that we're addressing those issues. Now, in the case of acute pain, taking opioids, there may be nothing we can do about that. We, need the opioids for acute pain relief, but recognize that that's going to cause constipation. And hopefully we can eventually get rid of the opioid. And when we do that, hopefully we can eventually get rid of that laxative as well. So again, pay attention, try to reduce and eliminate polypharmacy in these patients. All right, well, that's going to wrap up the podcast for today. Thank you so much for listening. If you enjoyed this episode, do me a huge favor. Leave a rating review on iTunes or wherever you're listening. Share us with friends, colleagues, students who could benefit from pharmacology education. I greatly appreciate that. We're almost at 5 million downloads now, which is way more than I ever could have anticipated. And a big reason why is you guys sharing this podcast with others that can benefit from the education. So I greatly appreciate that. If you got comments, suggestions, questions about study materials, anything like that, definitely don't hesitate to reach out. mededucation101@gmail.com. You can also track me down on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP, and connect with me there. All right. Thanks so much for listening. Take care. Have a great rest of your day.